lecture that I just gave 30 seconds ago? Cardio. What's the second word of that? Cardiovascular. Yes, cardiovascular, okay? So, what happens a lot of times is the vascular is completely forgotten, okay? So how I had this lecture before in your slides is there's a bunch of heme and then vasculitis at the end. I moved all the vasculitis to the beginning so that it is right after card. So it's cardiovascular. Okay? That's the only change I need, so don't come at me too hard. And I'll tell you why, because those often get forgotten. Okay? So we just talked all about the heart. We just said everything is compliance with that vasculature for most kids. So what happens when that goes awry? Okay? So now we are talking about the vessels of the kids. I have told you guys a lot of things that are my favorite. My favorite, I love bilirubin. I love TAPVR. But of all the pediatric diagnoses, again, what is happening? What's happening today? I'm going to switch sides. Oh, no. Of all the pediatric diagnoses that have ever been, and that will ever be, HSP is my favorite diagnosis of all of them. Do with that what you will. For this game, okay? Favorite diagnosis, Henoch, Schlandlein, purpura. This vasculitis, most common vasculitis in all kids, typically seen in that toddler to school age time. So yes, 3 to 15. Most of the time they're about 5 to 9. So you have that kind of early to mid-school aged child. Most of the time it'll follow something where they've been sick. So there's something going on with their immune system that starts to then have this inflammatory process into the small vessels. So we're talking about our small vasculature, okay? So it's a big distinction when we talk about the next vasculitis. Small vessels. When you have this inflammatory process then that results in all these different places, because this is vasculature, we think back to what kinds of immune complexes are made where you have mucosal cells. It's all IgA. Wait a second, we learned something else. What else had IgA? Celiac. Where's celiac? Oh, it's in the lumen of the gut. That's where mucosal cells lie. Any place where there is mucosal cells, there's going to be IgA. So the inside of your gut lumen has IgA. The inside of your vessels with those mucosal layer has IgA as well. So this is IgA vasculitis from your immune complexes of IgA that after some sort of URI are made and go implant themselves in the teeny tiny small vessels. That is the coolest pathology ever. I just think that is so interesting. And it's going to then go deposit into places that also have this mucosal lining. So if you're thinking, well, where else is that? Well, I have that in my kidneys, I have that in my gut, I have that in all of my capillaries on the edge of my skin. Well, that's exactly where you're going to see HSP then happen. So there's 4 main features of this, and I have beef with this. So you're going to hear my beef right now. Okay? So when we say, number 1, there is a rash, but it's palpable purpura. Now, is palpable purpura a rash? No, it is not. When you have palpable purpura, you have these IgA deposits into the small vessels that lead to extravasation and true bleeding into your tissues. Bleeding into your tissues is not the same thing as having an epidermal rash. Okay? However, we will call it a rash for sake of the way that it is on the diagnostic criteria. So you have a rash that is palpable purpura. So this is the only time we've ever talked about that, other than, what's the other time where you have a diffuse purpuritic meningitis, Neisseria meningitis, correct. So now you have this bleeding into the tissues, and it is gravity dependent. So most of the time, it's going to start on the feet or the lower extremities, work its way up, and it stops about the butt. So it's about where you see that. Can start as some urticaria, but most of the time it's much deeper than that. And so they have these kind of petechiae that will start, and they will coalesce as the bleeding gets significant. more into this palpable purpura in the lower extremities. So that's thing one. Thing two is some sort of joint involvement, arthralgias or arthritis. Wait a second, what was the other thing that we just talked about with kids and joints? Yeah. Yes, there are rheumatic fevers, the other thing. So you see this in these cardiovascular type things. We have some joint involvement. So this would be the other one. These kids have this significant joint pain. And again, most kids are not coming in saying that their joints hurt. That's not normal. If you have been around a kid, they'll play, they'll fall, they'll do whatever, and they'll run over to you and say, my elbow hurts. And then 2 seconds later, they're running off and playing again. Or my knee hurts, and then they're running off. These kids, it's so profound that you'll have an 8-year-old that will absolutely refuse to walk. They will just sit down, or they will just like, I'm literally not moving. These are the kids that have their families that are carrying their 9-year-old into clinic because the kid can't or won't walk. Either one. So refusal to bear weight and severe joint pain and some swelling is one of the second cardinal features. The third one is a crampy, achy abdominal pain. And that makes sense because you have this ischemia in the gut because that's the other place that you can have IgA deposits into those mucosal linings. The last one then is renal involvement. Again, IgA deposits down into those vessels. You can have a glomerulonephritis. It can present different ways. So certainly you can have hematuria, you have that blood loss into the urine. You can have hypertension, depending on how much of the immune complexes deposit, and even in cases of renal failure. This can present then with the significant edema that you see with acute renal failure. So you can have, and again, it's usually dependent. So it's usually in that lower extremity, feet, calves, scrotum, lower extremity edema. Certainly more rare is if it is much more severe. But what I really want you guys to think is palpable purpura, joints associated, abdominal pain, renal involvement. Those 4 are all because of those IgA deposits. So how are we going to diagnose these then? Well, we have to think about what it's not. So if we're talking about this, we'll talk about it later on in the lecture. If we're talking about immune-mediated ITP, thrombocytopenia, you're like, well, I have petechiae, but do I have the right number of platelets? In this instance, I do, so I guess it can't be ITP. All my cell lines are fine, so I guess that, my bone marrow is fine, I guess that really isn't leukemia then. Does this really look like abuse patterns? Is it really on the feet? And palpable purpura? Well, not probably. And then are they toxic? Are they ill? Is this a diffuse meningococcal? Or is this dependent and below and an 8-year-old that's refusing to walk? So this is your differential for HSP. Your workup then is going to be part of that to make sure you ruled out some of the other things. So my CBC can help rule out that it's not ITP, we'll talk about later. And rule out and help rule in leukemias. Your UA is again going to look for my spilling protein, and my BUN and creatinine is going to look at, are my kidneys involved in this? And then I'm going to look to see, do I have any blood that is coming from the gut, because I know that there could be those IgA deposits there as well. Your criteria, you need 2 of the 4, and this is always funny to me, because one of the criteria, if you look at the 4th criteria, it's you must be of pediatric age. So any child under the age of 20 is walking around with one of the 2 necessary criteria at all times, right? So if you're thinking, well, so really at 20, the body just can't do this anymore, you just don't get this over the age of 20. No, you still can, we just don't call it HSP then, they just call it IgA vasculitis. So it's no longer HSP, just IgA vasculitis. But so one of them for HSP is, are you of pediatric age? Criteria number 1. Criteria number 2, do you have palpable purpura? So if you have a child that is non-toxic in front of you with lower extremity palpable purpura who's a child, you can make that clinical diagnosis with nothing else. It's really cool because I know exactly what this is and how we're going to treat it. The other 2 is that if you have the gut involvement, so you have that bowel intermittent pain and ischemia associated with that. And then if you did a biopsy, where you would see the IgA vasculitis, that would be your fourth one. Most of the time, you see a kid with palpable purpura and you say, I know exactly what this is. That's how we're diagnosing it. This can last several weeks, up to months. So this can wax and wane. They'll have these intermittent times of these IgA depositions for up to about a year. So you can see this come and go. So it's palpable purpura. You can see that the joints can be involved for significant amounts of time. So there's usually no true joint damage. There's no mucosal layer inside the joint. So you truly don't have joint destruction of that. But what you can have is that mucosal obstruction. So in the gut, you can create a lead point, and that lead point can then be a source of intussusception, where the bowel is going to telescope on itself. So I have this area, has IgA deposits, now it's a lead point of inflammation, I intussuscept over it. Can be one of the complications that you see with this. And then renal involvement. So depending on how much of IgA is deposited into the kidneys, can be something that you will see with long-term renal. And this is why I know and love these kids well, is because when we say follow as an outpatient with routine urinalysis, we're seeing them weekly for UAs and then monthly for a while for a year. So these are the families that you're like, I know the diagnosis, I know what we're needing to do, and then you see them often. So you get blood pressure checks and a UA every week for a while. So you just get to know these families pretty well. They will usually be followed by nephrology, certainly if there is any kind of renal involvement, so that's what you really worry about. Eventually the IgA deposits will go away for the skin and your intestines. You worry about the long-term complications and scarring of the kidney. And that is why nephrology typically follows them. So you're continuing to follow with renal function, you're continuing to give NSAIDs for any of the pain. You're like, wait a second, NSAIDs can be harmful to the kidneys. Slightly different way that they are interacting with each other and okay to give, even in the setting of potential renal involvement. And then it's a very weird statement at the bottom. You're like, really, they have an excellent prognosis except when they have a terrible prognosis? Well, yes. So they do awesome. These kids have such great outcomes, except for the ones that have early and involved renal issues, and then they do very, very poorly. So that early renal involvement is the one that depends on which way you're going to go. Okay, so again, do with that what you will. Favorite pediatric diagnosis of all of them, all times, okay? Your second, vasculitis. So we're still in the cardiovascular section. So vasculitis number 2 is going to be Kawasaki disease. And Kawasaki disease is vasculitis, but we don't kind of know why. Kawasaki is a weird one. We don't really know what's going on. This one's in the small, but really we worry about those medium-sized vessels. So HSP was your small vessels. This one's now your medium-sized vessels. And this is the systemic vasculitis associated with a febrile disease. Second most common. From the name, you can see that it was named over in Japan. For this one, the way that I think about Kawasaki's is when you start thinking to yourself, this kid has 17 different diagnoses. Then I start thinking, wait, or is this Kawasaki's? I'll explain what I mean. So at first, they are normal stuff, kid stuff, and the URI type stuff, and a fever. And I expected the fever to, remember, follow my hand. So I expected day 5 to be significantly better as it followed that trajectory. Now, if I have at least 5 days of this true fever, that 101, 102 range, and it just continues, now I'm getting into that fever of unknown origin, fever without a source, all of those type of things from block 2. So I need at least 5 days or more of fever, and then I need a whole bunch of other things. So on their own, they sound like they could be something else. So if I said a URI with eye involvement, what was that from block 2? Adenovirus. Yep, if I said they have fever and cracked, dry lips and sores in their mouth. Hand, foot, mouth. Yep, if I said they have fever and a strawberry tongue. Yep, scarlet fever or a strep infection. If I said they have fever and giant lymph nodes, it's not unfair, but you could have mumps or lymphadenitis. If I said they have fever and pyuria, you're like, they have a UTI. So now you're down in the ER with these kids and you're like, this kid has fever of unknown origin, an adenovirus, strep, hand, foot, mouth, a UTI, and lymphadenitis. That's what they have. You're probably looking at a Kawasaki's. Okay? So when you have a kid where you're like, I think they have everything, it's probably Kawasaki should be on your differential. So all of that to say, they're presenting with this fever multiple days, where there's eye involvement, so limbic sparing conjunctivitis, right around the area of the iris, you have limbic sparing conjunctivitis, dry cracked lips, strawberry tongue, sterile pyuria, lymphadenitis, feel terrible, and potentially even that scarlet fever-like rash. Your subacute phase then, again, will start to look like something else. So the fever will go away, and now their skin desquamates. So we're like, well, we looked at a lot of those. Is that parvo? Is that hand, foot, mouth? Like, what's going on with this kid? And then their platelets are really high. So this is one big difference. Highlight this. It's a difference between adults and kids, is that high platelets in children are an acute inflammatory response. It's one of the things that their bone marrow will push out in response because they're so worried that the child is going to bleed from somewhere that the bone marrow just pushes platelets out. It says, make sure they don't bleed. Okay, so an acute inflammatory response will be increased platelets in kids. In adults, it's not that same way. You will need to do a full workup for increased platelets in adults, not in kids. And then you start worrying about this coronary artery aneurysm. So what do I have here? These medium-sized vessels, these antibodies that we assume are going to go attack and create this aneurysm. That's Kawasaki's. Here's an example then where you might think that it's just other things, where you have this conjunctivitis, you have dry, cracked lips, you have, oh my goodness, this may be the cheeks. Do I have parvo? Do I have strep throat? Do I have hand, foot, mouth? Do I have all these things? So it looks like the disease of everything. Desquamation, strawberry tongue, lymphadenitis, you're looking at all of these things. So here's your diagnostic criteria. So the fever of 5 or more days, I have some of that conjunctivitis, I have something of the mucous membranes, something of your extremities, so this can cause peripheral edema. So when we talk about this later in this lecture, you'll have swollen hands and feet, maybe something else there. A rash around the trunk, lymphadenitis again, and then I love the last criteria. Can't be explained by anything else. It's fantastic. What is your job then as that primary care PA? Well, your job is going to make sure that we are not missing some other big bad infection. So I'm taking a sample of the urine, I'm taking a sample of the blood to make sure we're not missing some obvious infectious etiology, and then looking at all of my inflammatory markers. So my leukocytosis, if it's there, ESR, CRP, so that's what we're going to follow over time. When you're saying, ooh, now I think this is Kawasaki's, I'm worried about that coronary artery aneurysm, I better call cardiology. Yes, you do need to call them to get an echo, but this is not an emergency thing. This is a thing that you're going to say, I need a baseline, I need something in a couple of weeks, and I need something in that longer follow-up. And this is one of the first times I was yelled at as a resident because I called a cardiologist in the middle of the night for an emergency echo. And they said, you do not need an emergency echo. I will see you in the morning. Right? Because you're not worried that a coronary aneurysm is just going to spring up overnight. You're worried that over the course of several weeks, you're going to end up with an aneurysm. So you do need that early echo, but not emergent. They get hospitalized. The reason they get hospitalized is for 2 things. You need IVIG, so intravenous immunoglobulin. Right? So people can anaphylax to that, especially kids. You want to make sure they are hospitalized for that. And this is to try to combat any of those antibodies that are going to attack those medium-sized vessels. And then high-dose aspirin. So your high-dose aspirin is for all of your inflammatory process. So this is another one. Cardiology is going to manage both of those things. You need to just make sure that they have their basic workup and that they are hospitalized. This is an algorithm. If you just like studying this way, it functionally gets you to the same thing as this one. So if you have that, don't worry as much about this. All of this says is you can get to the diagnosis of atypical, and that's really beyond our scope. So those are the two vasculitis that I want you to know. Okay, the next section that we go into for this over is now we're into heme. And so the reason that vasculitis is put with heme is that a lot of times it's the vessels that carry the blood. And so vasculitis, everyone for a lot will look at each other and say, well, that's cardiology. And we'll say, well, that's nephrology. Well, that's hematology. So it gets kind of lumped together a lot of times with hematology. So it kind of segues into hematology. So when we're looking at, so shift gaze, so cardiovascular, put those together. Now we're in what is inside those vessels. So when we're looking at anemia for children, the thing to look at is that it's another one that you have to know, what is my age, and do I have a boy or girl that is pre or post puberty? It's another one that you're like, I need another chart. Yeah, you do. I'm so sorry. Because those things will matter. When you see your lab results in Genesis, all of those standards that you standardly report, they are all adult standards, okay? So you are going, if you see children at all, or if you have your own children, when you pull up pediatric labs, it might be like high, low, just all over the place. And people will freak out to say, these are the adult standards, let's look this up for the child, for their age and their stage. Pediatricians hate this, so we get all these calls. Frantic families for very normal levels, but again, it's the age, it's the adult values. Your history is going to be your history. You're still going to say, do you have something that could affect your red blood cells? Are you taking something? Did you travel somewhere? Do you have a family history that can impact those red blood cells? Again, most of the time you won't notice something on exam. Kids are going to compensate really, really well until they get down into a hemoglobin of 7 to 8. What might their heart rate be doing at that point? Tachycardic, yep. What might you hear on exam? We just had a cardiovascular lecture. What might you hear? Yeah, you might hear a Still's murmur, some of those functional murmurs because you have that increased flow going. Your physical exam, then again, if you have more breakdown, you have more of that breakdown of hemoglobin, you might have more jaundice. If you just don't have enough, you might have more pallor. And so your labs, and again, I know we're not trying to go over heme again, but just those differences with children and adults, when we'll talk about the different components of your CBC, your reticulocyte count, and then your smear. So here's the chart. Please do not memorize the chart. The same thing. Do not memorize the blood pressure chart. If I need you to know them, I will give you the blood pressure chart. I will give you these charts. I just need you to know how to read them. Okay? So, when we talked way back in block 1, most of the time we are determining if something is normal based on the standard deviations with children. So we use that bell curve. So we say if you're outside of 2 standard deviations of things, that's when we consider it in that kind of abnormal range. Think about block 1 where we did that with failure to thrive. If you were below 2 standard deviations for weight, that was when we got into that failure to thrive range. Okay? Much the same here. You have standard deviations. So when you are 2 standard deviations below the mean of something, that is when we are saying you are in the anemic range. Okay? So if we're looking at, let's look at the 1-year-olds. What do we get at 1 year old for screening for all 1-year-olds that would associate with this? A lead in a CBC or a lead in an H&H. Yep, so this is exactly what we're looking at, these 1-year-olds. So I get it back and I say, well, I have a hemoglobin of 12 and I have a hematocrit of 35. in a 1-year-old? Is that normal or is that abnormal? Totally normal. Yep. If I have a hemoglobin of 10 and a hematocrit of 32, slow. What if I have a hemoglobin of 11.4 and a hematocrit of 32? Slow, right? You're going to take the lowest of the two of those. Okay? So that is how you are reading it. So you have what the mean is, but it needs to be to correctly say this child has anemia or not. Needs to be, is it below the lower limit? And that lower limit is 2 standard deviations lower than the mean. That's how this chart is made. Right? And so then once they hit puberty, now you're getting into that more adult physiologic response. So now you need to know, is it male or female? And so in the chart, when you get to phase 2, it'll do male and female for all ages. For us, if I need you to interpret something, I'll give you the appropriate chart, just on age and then at the later stage. But point being, any age, check the chart to make sure that it is age and sex appropriate. One thing that gets asked every semester, we look at MCVs. Yes, those also have these 2 standard deviation lower limit. And so, yes, if you are working in peds and you are getting into the nitty-gritty of this type of chart, yes, they have lower MCVs. For our purposes here, we're going to use that adult standard of less than 80 is microcytic. Okay? So know that it exists, know that it is out there. The way I want you to be able to read the charts are hemoglobin and hematocrit. Be aware that MCVs also have that same lower standard deviation, but it's okay to use your adult values for our purposes here. Okay? So now we determined they have anemia or not. So I used my hemoglobin and hematocrit, and I have determined that they're anemic. Now what type of anemia? Oh, well that is by our MCV. So we said we were going to use 80, so something less than 80. We have your microcytic anemia, hypochromic microcytic, it's too small. Your normocytic is between 80 and 100, and your macrocytic then is above 500. Most of the time, if you have your really small ones, your microcytic, you're missing some element most of the time, and in our world, we'll talk about this specifically, most of the time it's iron, could be lead, could be an underlying thalassemia for this kid. Most of the time if it's normocytic, so you're making them, they're the right size, you just don't have enough of them. It's probably something systemic. There's a chronic issue with this child. And then macrocytic, they're again missing something, but it's missing something on the other side. B12, folate, thyroid hormone, something like that. And then your hemolytic diseases is going to vary very, very widely. When we talked in cardiovasculature, we said that children could do really well if they adapt over time to those pericardial effusions. They don't do well when it's rapid. Very similar response here. So a chronic anemia, they tolerate really well. Over time, they're able to compensate for that. They have the tachycardia, they might have some of that flow murmur, but they compensate really well. It's the kids that don't compensate, it's when it's very, very acute. They have this rapid blood loss, so now they are unable to tolerate that. And you see that depends on, is it an acute trauma and the child is unable to compensate, or is it something more acute and you are seeing symptoms much faster than that. So you're going to determine is it acute or chronic, how low is it, it's going to determine if you give them accurate blood tests. The presentation is going to look like what we just talked about a minute ago. So certainly if they do not have enough of these box cars carrying oxygen, they won't have pallor. If they have too much breakdown and you have that processing hemoglobin, you will have jaundice. And certainly if your body, if their little bodies are pulling out abnormal cells, it can be large spleen. If they are bleeding somewhere, you have purpura, joint issues. If they're bleeding into a joint, you can have both spleen and liver that are big, growth failure because it's carrying the oxygen. So if don't have this, potentially you have failure to thrive. And then depending on if they're missing something, there's like a macrocytic anemia, you could have those abnormal neuro symptoms as well. So your CBC, so whenever you get out, doesn't matter what you do, but you should have a process, much like you read x-rays, you should read CBCs the same way every time. So I read them the same way every single time. So number one, I want to know, is there an anemia? So I have hemoglobin and hematocrit with the age in the chart very first. Is there an anemia? What type of anemia based on your MCV? And then I look at the rest of the cell lines. And then do I need something else with that? So whatever your process is, just make sure you are doing it the same every single time. The other thing to look at is your red blood cell distribution width. So I think of this as your Krispy Kreme donut factory, right? If you are making the same number of donuts and they are coming out and they are looking okay, it's telling me something's going on inside the process, I can't get enough out, or something is wrong with the machine in the back, versus I'm just throwing stuff out there because they're getting destroyed on the outside, so I'm just throwing out donuts as fast as I can. It doesn't matter what size or shape they are. That's what's going on with my RDW. So it's going to look at, do I have more destruction? Do I have decreased production? So that can help you with that. Again, just a reminder from him that you have your hypochromic, so you're normal, A is normal, B is your macrocytic, big, bright, C is your microcytic, and then you start seeing some of the other pathologies, schistocytes, white cells, all those other things that we'll get into. Just a reminder of what those look like. Your reticulocyte count, how many baby red blood cells are being pushed out the nest? So that's what that's looking at. So when I have anemia, do I think my reticulocyte count is going to be high or low? Should be high, right? So if I have something, we talked about this in block 2, if I have an issue where I have sickle cell and parvo, right, where you have now an aplastic anemia, so transient, but I have low red blood cells and a low reticulocyte count. Don't expect that. So that can be super helpful to determine what is going on in this underlying thing. So elevated would be expected, pushing them out the nest. And normal would either be, I haven't gotten to severe anemia, or it's a really acute anemia. So think about these reticulocytes, they have their feet up on the desk, and so if it's really fast, they just are like, oh crap, I haven't responded yet. And then if it's decreased, something else is going on. I have an underlying disease, there's a problem with the bone marrow, it's attacked my precursor cells, something like that is going on. What I don't need you to do is memorize this, but to be aware of it. This is more of kind of a phase 2, so don't memorize, but what you're really looking at is, again, do I have anemia, yes or no? What type, macro, normo, or microcytic? And then what is my reticulocyte doing? Because not everything is an iron deficiency anemia. When you get down into that, you can see that you have a large differential for each of the types. So that will matter much more for phase 2 when somebody is looking at you and asking you for a 15-step differential. And I see your faces, I know that means it's another 10, so let's take 10, we'll come back at 11:30, we'll power through for another. What you look at would be a smear. To actually have a human being who does this all the time, look at all your cell lines underneath the microscope to say, what are the actual cells looking like? What can I actually see? What things that are not calculated by a machine are there on this slide? The other things to think about, common things being common. What is my iron studies? What is my iron level doing? What is my ferritin or my storage form of iron doing? And what is my transferrin? How well is it going between active and storage form? And then my lead level. Do I have a child that is drinking the water in Flint, Michigan, right? And I have increased amounts of lead, things like that. Or eating paint chips. That's the one that's always on the pants. The child that's eating paint chips. So we're looking at the microcytic anemias. Reminder, I don't love the acronym, either one. I don't like tails or flats. I like faults because it tells you the order of what is most common in children. So the most common thing for a microcytic anemia is going to be your iron deficiency. The second thing is going to be your anemia of chronic disease, then lead from the kids that are eating paint or drinking the water in Flint, Michigan. Then you start getting into more of your genetic things, your thalassemias or your sideroblastic anemias. So, however you want to remember that, but iron is the most common, anemia of chronic disease is next. So, faults, I always end up, it's the fault of somebody who made this that they didn't put it like that. So, again, most common thing being common is iron deficiency anemia. So, for kids, when we see that they have a microcytic anemia, we assume, that is how we practice, we assume it is going to be an iron deficiency anemia. 50% of a global population of children at one point will have iron deficiency anemia. That's a wild number. If we have 50% of something, that's a lot of children. So that's why we assume that it is going to be an iron deficiency anemia. So we think about, when did we transition to cow's milk? 12 months. That's why we get that study at 12 months. Because when we switch from having an iron fortified formula or breast milk that has iron in it to a calorie dense liquid that does not have iron in it, I want to know, is that child already starting behind the 8 ball and they are already low in iron? So that's why we get it at the 12-month mark, just before we start them onto cow's milk. The other thing that times that you see this is when females start their menstrual cycle, so now they have blood loss. If you have a kiddo that loves to pick their nose and they have recurrent epistaxis or any kind of intestinal bleed, so think we just talked about HSP, that might be an episode that you would see something like that, for example. And then worldwide, the most common condition is going to be from a malnutrition. So common things being common. So when we get that 12-month-old either H&H or CBC, however you decide to practice, and they have a low hemoglobin and hematocrit, even if you don't have an MCV, even if you don't have iron studies, you are going to first line assume that it is iron deficiency anemia because of how common it is. If you have the full CBC, then yes, you will have the H&H that's low, the MCV that is low, your RDW that is high, and then overall reduced RBC count. If you got it, you would have iron studies that would show your decreased amount of your storage iron because it was already used up, a decreased amount of your serum iron because it was already used up, and an increase in your total iron binding capacity because it's sitting out there being like iron, anywhere, 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 anywhere. So it is high. However, in general, since we're assuming it is iron, you don't need to go poking this child again this first go round to say what their iron studies are. You're going to assume that it is that and treat it as such. So when I say treat the kiddo as such, we are going to give them oral iron. 3 to 6 milligrams is elemental iron per kilogram per day in a couple of doses. Now, has anyone ever tried to take liquid iron before or tried to give their child liquid iron before? How does that smell? Horrid. How does that taste? Even worse, right? How does the version that the DoD gives out smell and taste? Particularly rancid, right? They have somehow found the lowest bidder that makes a particularly awful version of it. So this picture is literally the brand that I will say, I am happy to give you a prescription for this. It will taste terrible. This is a much easier way to get this down your child. So you learn some of those things. Different brands that are on Amazon sometimes are a lot easier, but it is available to prescribe elemental iron form. The child often, yes, ideally you're taking it in a split AM and PM dose, but a lot of times you're trying to just get down what you can get down. So ideally you're not taking it with dairy products, and you are taking it with a vitamin C analog. So you can get them to take it in the morning before they've had any other dairy products with an orange juice. It's going to be optimal with a version that they are likely to get down. So That means that your most likely cause of when they come back and they're still anemic is what? They didn't take it. Yep, non-compliance for one reason or another. The kid spits it up. The kid hates the taste. It smells awful. They were taking it with milk, something else at the same time. So some sort of non-compliance is usually your first line issue with iron. Why do you treat it for 3 months? Yes, that is the life cycle of a red blood cell. So we need to have a full life cycle to be able to see how our treatment works with that. So you could, for your, if your education, if you're looking to see, am I on the right track? You can look in a few hours, a few days even, to say, oh, I do see now my reticulocytes are increasing because I have new little babies that are being pushed out the nest. If I see in about a month, I'm starting to see that we have some of those corrections in your overall number and size and your storage form, but it's really going to take that full life cycle to see if you truly have been effective in your treatment or not. Again, if you're not, a lot of times, most of the time, it's going to be a non-compliance issue. It can also be a constipating med. Iron can really just kind of freeze things up there. So remember, if you have a child coming in for abdominal pain and you're thinking, I need to do a clean out, making sure you know what medications are on can be super helpful with that. Your age will matter in these kiddos. So if you had a child that for whatever reason is coming from the NICU or they were born prematurely, depends on what they're feeding. So iron fortified formulas are going to have a little bit more iron often than breast milk is going to have. So if these children for whatever reason are not going to be starting solids, you might want to start thinking about an iron supplement at about that 4 to 6 month mark. They're going to be continuing on breast milk or formula only. At 6 months, they should be starting to have some of this iron fortified formula, or iron fortified solid foods, way back from block 1. Again, eat it over your head. For 1 year, limit the cow's milk intake. The family that went to Costco and got 7 gallons a week for their 1-year-old who would drink a gallon of milk a day, was functionally all this little girl drank for all of her calories, incredibly iron deficient. And for that reason, she was not having any input of iron. So you're trying to decrease it to no more than 3 8-ounce glasses of milk a day, which is still a lot of milk. You really are thinking about that's a lot of milk. And then making sure that menstruating females have some sort of iron supplementation, ideally a prenatal vitamin because they are of childbearing age with iron in it. A very quick word on your normocytic anemias. If you have low hemoglobin and hematocrit, so they're anemic, but the size of your individual cells is normal, you need to go looking for something else in these kids. It's telling you, well, we're making sort of normal cells, we're just not making enough of them, so something else is functionally going on. So looking for some sort of chronic disease. Is this renal? Is this gut? Is this infectious? Something else at a chronic state is going on. So if you see a normocytic anemia in a child, go looking. Something else in the history, something else on the exam is going on. That's all I'll say about that. Your macrocytic anemias then, again, these are those big plump ones. They're very, very large. They have a lot of color to them. So this one, I don't like any of the acronyms, so just pick an acronym that you like. Most of the time people have no problem remembering if it is folate or B12, those are the easy ones. The other ones to think about in a child particularly is your thyroid. So hypothyroid hypothyroid will be the third main cause of that. I suppose you could have an alcoholic child, so not something to be forgotten, but things that you would see. Once you start replacing this, you see a pretty quick response into this, and certainly if it's something underlying, you're treating that organ. A question that I had on my boards and that I have seen on recurrent ones that have popped up, it talks about a child whose family wants to not use formula or breast milk, they want to use goat's milk. And goat's milk is a functional deficiency of folate. So they present with a macrocytic anemia without any of your neurologic symptoms from a folate deficiency, so from that goat's milk. So definitely don't recommend goat's milk. That's the takeaway from that. Your aplastic anemias then. Your aplastic, I don't have anything going on in this bone marrow. Nothing is happening at all. So most of the time, I have no idea even what has caused this. Some of the time it can be different toxins, different drugs that are causing this, different infections. And I will need hematology to go in and do a bone marrow biopsy to really look at what is the marrow doing. I can see the periphery of this on the CBC, but what truly is the marrow doing? So we'll see low reticulocytes, low neutrophils, low platelets, low H&H. So everything is down, all cell lines down. So that's when we worry about that. Those are the kids that are going to end up needing a stem cell transplant because nothing is working at that point. So we need something to spark the bone marrow again to be functional at that point. Okay, so those are all the anemias. Now we talk about your hemolytic anemia and the anemia of we have increase in our breakdown. Okay, so is this going to more likely have pallor or more likely have jaundice? Jaundice. So when we are looking at this, we're looking at different types. So we're looking what's wrong on the inside of the cell that's causing it to be destroyed. What's wrong on the outside of the cell that's causing it to be destroyed. What is making a tag marker that's making the immune system come and destroy it? What other things on the outside are contributing factors that go then and attack? And then vasculitis, because that's how we connect all these together. Right? So we're looking at either something on the inside, the outside, something is attacking these red blood cells as part of the disease process. So these are those things that we're looking at. Because it's being destroyed, and you already had it. You had an increase in that bilirubin, breakdown of the hemoglobin. Thus you have free hemoglobin running around, and then decreased haptoglobin. So haptoglobin, if you're looking at that marker, is going to bind to your free hemoglobin. So this makes sense. If your cells are lysing, and you have all kinds of free hemoglobin running around, that is going to bind to that haptoglobin, and thus your haptoglobin is much lower. If you have them hemolyzing, you can see schistocytes, where your body has played Fruit Ninja with your red blood cells. Can have some red blood cells into your urine, and then since they are lysing open with hemolysis, potassium is an intracellular ion, so it comes out, thus you have hyperkalemia. Schistocytes again, Fruit Ninja of the body. Thalassemia. So did you guys talk extensively about thalassemia in Heme? Okay, we will try to hit that relatively quickly. So as a reminder then, you have normal production of hemoglobin. Hemoglobin has your two chains, or four chains, 2 alpha, 2 beta. Of the alpha chains, 4 genes, 4 proteins, 2 chains. Your beta, 2 genes, 2 proteins, 2 chains. So there's a lot of different places that those can get messed up in. You need all of those to go correctly to make a functioning red blood cell. So functionally, what this is going to make is a platform. So this platform together then creates a place where your iron, lead, and all of those things, you don't want lead to sit there, but your iron can sit and the oxygen molecule can be carried. So functionally, if you don't have this intrinsic platform that is made correctly, you will not be able to carry that oxygen molecule. So 2 alpha units, 2 beta units is what we are going for. So for alpha thalassemia, alpha thal has more options because you have more genes, more proteins to make that alpha side of the platform. So if you have one gene that has some sort of mutation, we are okay. We still have 3 of the 4. So functionally, the way to think of alpha thal is if you have more than the majority, you're doing okay. So if you're missing 1 of 4, you're still doing okay. Really, you're only going to be able to detect this if you did genetic studies. If you have 2 mutations, now you have the trait. So you're having 2 of the 4 that are going to make up these proteins. So now I do have a microcytic anemia. So this would be an instance where I've done the H&H. I said this has to be an iron deficiency anemia. I know it. I've given iron for 3 months. I had no change. Man, this child must be non-compliant. Let's do another 3 months and talk about compliance. Wow, I've done 6 months of iron and I have no change. I need to start thinking maybe this is the thalassemia, and that's more of my differential. So an alpha thal trait with these 2 mutations would be what you would see on your differential for a non-responsive microcytic anemia to iron. Make sense? Your 3 mutations then. Now you have hemoglobin H disease, a little bit more. I'm missing more than the majority of my normal chains, my normal proteins to make up this platform. And so now I do have a truly microcytic anemia and some hemolysis going on because my cells are not created with enough stability to maintain their life. And then 4 mutations. So I don't make any of this alpha platform, none of the right proteins, none of the right chains. So I don't have this stable platform to be able to carry the hemoglobin, to be able to carry the iron that carries the oxygen molecule. Thus, I am not able to get oxygen to these tissues, no flow, no grow. My baby does not grow, and I do not make it in utero. That is the function of the hydrops fetalis that you see with this. How about beta thal? Well, beta thal is a little bit different because do you remember what can substitute for a beta chain? Hemoglobin what? What type of hemoglobin? Fetal hemoglobin, yes. So whereas with my alpha, I didn't really have as much of an option, but when it's something wrong with my beta chains, well, maybe I can just make more fetal hemoglobin, and it's not a perfect platform, but it can suffice. Okay, so now if I have 1 gene on that beta, that's an issue. I have that same scenario where I still have a majority, still have 50%, because it was the 2 genes, I need 2 proteins to make the 2 chains. So in this one again, I have your mild microcytic anemia. So that would be another one where I give an iron, check the compliance. I've done this over and over and it's not helpful. Might be a beta thal minor. The other one is now where I have my 2 gene mutations, so it's different than a deletion, but I have my 2 mutations, so I cannot make an appropriate platform, but I am able to shunt enough over into the fetal hemoglobin, so I can make the 2-unit alpha, 2-unit fetal hemoglobin to be able to still carry oxygen. It's a little different than now if I have 2 gene deletion, so now I just don't make any of that, and thus becomes transfusion dependent. I cannot make enough of the fetal hemoglobin with alpha subunits to be able to have enough oxygen carrying capacity. So this one, they will end up with transfusions, recurrent transfusion, iron overload, hemochromatosis, because they're having to have these regular transfusions because their body cannot make enough of the platforms. They also will end up with iron chelation therapy because of the hemochromatosis. So just a reminder, deferoxamine would be one of those things that you see. And eventually these kiddos will need some sort of a hematopoietic stem cell transplant because the marrow is not making functional hemoglobin, functional red blood cells. Those are your thals. So things to think about if you have a non-responsive iron deficiency anemia. Takes us into another option that you could have going on, so sickle cell disease. So you're in this case, you're making hemoglobin that doesn't always stay in that nice inner tube-like system. Interesting history of this that I find interesting at least, is that these red blood cells, when they sickle, they are not able to be infected with malaria. And so there is a evolutionary helpful property where I might sickle, but I don't then carry malaria and cause death from that. So these sickle cell diseases, what I don't need you to remember is the specific amounts that are causing trait versus anemia versus disease. All to say, the more you sickle, the worse that your process is from trait to anemia to having your disease. So the more hemoglobin S that you make, the worse your outcome is. This is one of your newborn screenings that we do, so we usually pick this up pretty early. If they have a trait or they have a specific mutation that is not picked up, your electrophoresis will be how you diagnose this. So functionally, the way to think about this is that I have a red blood cell, just round, looks like that inner tube, and anytime I have something that is not physiologic, perfect conditions, I have an opportunity to sickle, and I might sickle, right? So anything that's gonna cause that, so I have a fever, I'm hypoxic, I'm dehydrated, anything that changes that perfect physiologic state, I'm now gonna sickle. So if you think about anytime a kid gets sick, that's functionally where they're at. So they have a sickling crisis. And when that happens, when they sickle, they can either clump up together and cause a clot, they can go sequester themselves into an organ somewhere, or they can then block off something and cause an infarct downstream. So sickled cells are then what is the problem. When you have this sickling plus a fever, this is a medical emergency. So this is one of those life, limb, or eyesight. This is a life one. So this would be, this kid needs to go to the ER right now. Do not stop, go. They have to go. So for this, potentially, and really in all cases, they end up with us on the unit. As with everything, under the age of 6 months, worry that they are going to be in a worse situation, and you can start seeing the spleen having trouble as early as this. As the spleen is starting to take out those sickled cells, they're already seeing some splenic dysfunction. By the time they're 5, they're functionally asplenic, because the spleen has done a lifetime of work in those 5 years. So the spleen is going to take out those encapsulated bacteria, which are your encapsulated ones. Strep. Neisseria, Hib, and then Klebsiella is another one. Don't forget that one on there. You can see that. And so those are the ones that you worry about. But these kids are going to have a horrible infection with an encapsulated bacteria because the organ that's getting those and pulling those out is not functionally by the time they're about 5. If your boards love this one, a osteomyelitis. For kids with sickle cell, you will see with salmonella or staph. That's just one of those things, kind of those buzz things. If you get a salmonella osteo, you're like, ooh, they're trying to tell me that this kid has sickle cell in your board question. When you have that aplastic crisis, thinking back into block 2, so we worried about those pregnant women in their 2nd trimester, and then we also worried about kids that had sickle cell because that parvovirus is going to attack these kids and cause that transient aplastic crisis that they can't handle because they don't have enough of the precursors, and they're having constantly pulled out of circulation sickled cells. The presenting symptom for these kids is going to be a dactylitis. So they will be fine, and then one day they have these big sausage fingers or sausage toes. Extremely painful and very, very large. So you're like, oh my goodness, where do these hands come from? Just big hands, big feet. Anywhere then that you could sequester or have an infarct downstream where you have poor circulation, you worry that that is going to be a problem in sickle cell. So the femoral head is one of those. So you see the avascular necrosis there. You can also see priapism with males. If it sickles, if you get sickled cells into the penis that then cannot extravasate out, and worry about that as well. And certainly this would be a reason that you have neonatal or pediatric strokes if they have a thrombus into the brain. This is an example of the dactylitis. A normal hand on one side, and then once this hand has significant inflammation, significant sickling in the periphery, you see this big hands, big feet, sausage hands, sausage feet. These painful, so a couple of things. You can get the vaso-occlusive, so all these cells sickle together and they occlude somewhere. So the downstream is your issue. So you have a pain crisis from these vaso-occlusive events. So that would be the first thing, is that you have to get them back into a physiologic state. So something has caused them to sickle more, and it's telling their body, put them back into a physiologic state. Make sure they are hydrated. Make sure they have pain control. Make sure that they do not have a fever. Make sure that they have supplemental oxygen, supplemental fluids. Get them to as much of a perfect physiologic state as possible to help manage that pain crisis. What you worry specifically about is if you have acute chest. And for the longest time, I was like, I do not understand what this is, because on chest x-ray, it looks like a pneumonia. You're like, yes, pneumonia, or any kind of a pneumonitis, is going to have that infiltrate into the air sacs. This acute chest is when you have a vaso-occlusive crisis in the vasculature of the lungs. So it looks the same on a chest x-ray, but it's at two different sides. One's the aeration, and one's the vasculature. So this is a vaso-occlusive crisis into that chest. Looks like it can infiltrate on exam. It's very, very, very painful. And this is what we really worry about, is if I have so much vaso-occlusion in the lungs, I am unable to aerate and I am unable to oxygenate the rest of this child. And so that is why acute chest is so concerning and is something that they always end up staying in the hospital with us for. Again, you're putting them back in a purely, as much as you can, physiologic state. Oxygen, fluids, pain control, antibiotics to prevent a secondary infection, bronchodilators, anything you can do to help with that vaso-occlusion is going to be of utmost importance. Yes, I would say, yes ma'am.
Sorry, ma'am, just a time check.
Let me see if we're at some sort of stopping point real quick. Let me finish up sickle cell and then we'll call it. Okay, so most of the time you're going to be admitted for this, so I would say that in no case you're going to do outpatient because you are so worried about what this is going to be, unless you have fantastic follow-up. They live on post and you see them every week and you know that they're going to be there. The rest of the time you can think about whatever it is, but always hospitalized for acute chest, for an acute splenic sequestration, and then your aplastic crisis. These ones are all going to be managed by hematology. The thing that you're going to do to try to prevent that sickling is to keep as much of fetal hemoglobin as possible. This is again a problem with that beta subunit. So if I can shunt as much away from the beta subunit into the fetal subunit, that prevents that sickling. So hydroxyurea is what's going to be used to help prevent that sickling. Shunt everything into your fetal hemoglobin status. And some of these kids then are good candidates for the stem cell transplant because the precursors be correct then. Finally, at a PA level, the thing that you will need to make sure that they have is that as soon as you reach diagnosis, they need a daily dose of an oral penicillin prophylaxis to make sure that they are not having those encapsulated bugs hitting them. And the extra folate, make sure they have all the pieces to be able to make the correct chains. One last comment on that with the prophylactic antibiotics. Something to think about as a provider is when you give somebody penicillin, if you give them oral penicillin for this baby to take, it's only good for 2 weeks. So working with your pharmacy to say, can we give them something where they can mix at home? Can we do something where they don't have to come to the pharmacy and wait every 2 weeks for a lifetime? So working with your other ancillary providers to make something make sense for this family is going to be of utmost importance. Much like rheumatic fever, this is forever with penicillin. So what can we do to make sure that it works for this family? We will stop here and we will plan to just go